diagnosis, planning, implementation or interventions, and then evaluation. We always have to think about how we will assess our patients, diagnose them with a nursing diagnosis, which is separate from a medical diagnosis, and then we have to plan our care. How are we going to meet the patient's needs? We will intervene and we will implement those interventions, and then we have to evaluate the interventions that we performed for our patient. And we also want to make sure that the evaluation has a specific time frame. So also things that are important to consider as a nurse is critical thinking. That means you're thinking outside of the box. When you get bits and pieces of information from your patient or when you assess them, you have to think, what does this information mean and what are the implications for caring for this patient now that I know these bits and pieces of information? We also have to use clinical judgment, and so that comes with time and with experience. We have to say, okay, this is a potential outcome for this patient. How can I mitigate these circumstances, or how can I mitigate this situation? What can I do as a nurse to help the patient have the best outcome? The pie chart that you see on the right of this slide is from the test plan for the NCLEX RN, and it basically breaks down the parts of the NCLEX and the percentages of the NCLEX that will be tested, or the parts that will be tested. So for example, 15% of the NCLEX will be on pharmacological and parenteral therapies. Okay, so if you are not too good or you need maybe a little bit more brushing up on your pharmacology, take your time to do it now because it is a big chunk of the NCLEX. A detailed test plan for the NCLEX can be found on the NCSBN website, and the link is embedded into this PowerPoint. Without any further ado, let's talk about perioperative care. So perioperative care consists of three particular phases. It's preoperative, intraoperative, postoperative. And we're also going to talk about some common postoperative complications. And I always want you to think, as a nurse, what am I going to do to actually assist my patient to prevent potential complications? Okay. All right. So in the preoperative phase, these are procedures or teaching that will be completed prior to the surgical procedure, and it also is designed to reduce the potential for complications and postoperative discomfort. We want to relieve the patient's anxiety and increase participation in care, and a way to do that is to provide anticipatory guidance. So an anticipatory guidance means I will tell the patient what to expect. So caring of a client before surgery. So here's some of the nursing interventions that we're going to perform. We will take the client history. We will identify any risk factors. So for infants, elderly, and chronic illness, we'll look for those things. If they have malnutrition, respiratory conditions, if there's obesity present in your client, and any emergent procedures that they have had performed in the past. We will check for informed consent. The nurse may be the witness for informed consent. We will also perform a baseline assessment, and so that is pretty much a head-to-toe assessment as well as your vital signs. We want to know what was the patient's baseline before they go into this procedure. We want to assess for allergies, verify the patient's NPO status, and NPO means nothing by mouth. We also want to understand the medications that the patient has been taking or may have to stop taking or will be taking during the procedure. So that's why it's very important to assess for allergies. So we also want to provide patient teaching about the medications. For example, if the patient is going to have anesthesia, let the patient know that there may be different routes that anesthesia can be delivered. It could be inhaled, given IV, regional anesthesia, or topical anesthesia. Also, as a nurse, we have to understand that antibiotics may be given prophylactically prior to certain procedures. Anticholinergics may be given to reduce mucus secretion. Narcotics may be given for pain management, and sedatives may be given to relax the patient or have them in a sleeping state. Diagnostic tests may be ordered, and so that includes a full laboratory profile. So that includes your CBCs. It could be a full metabolic panel or a basic metabolic panel, but a laboratory profile is something that you could expect to have to draw as a nurse. You may have the patient get set up for a chest x-ray or an ECG prior to surgery. Pregnancy tests may be taken for your female patients. So when you're educating the client in the preoperative phase, you want to make sure that you address any fears and anxiety that they may have. And again, you will do that by providing anticipatory guidance and actively listening and engaging and seeing if they have any concerns. For medications, you want to make sure you're educating the patient or the client that they should hold any anticoagulants for 7 to 10 days prior to surgery. So we're talking about anticoagulants such as warfarin or aspirin. And that will create a situation if they do not hold those anticoagulants where they have a high risk for hemorrhage. We also want to educate the patients on the use of the incentive spirometer. We want to educate the patient on the actual invasive procedure. What is going to happen? What is this procedure about? What is it step by step that's going to happen during the procedure? We also want to educate the patient on the different routines. And again, that is providing anticipatory guidance about what is happening before, during the procedure, and then afterwards. So in the intraoperative phase, this phase begins when the client enters the surgical suite and ends with a transfer to post-anesthesia recovery area. So in the intraoperative phase, this is where the patient is actually going to have the surgery or the procedure performed. So your nursing focus during this time is on safety, client advocacy, and health team collaboration. The Universal Protocol, which is a safety initiative from the Joint Commission, says that we should conduct a pre-procedure verification process. So we should also mark the procedure site and perform a timeout before starting the procedure. The timeout will be done by calling verbally in the OR saying time out. We will identify the patient, by using the armband, and all members that are involved in the surgery will also make sure that they understand that this is the correct patient. And okay, what is this patient going to have done? Okay, so that is a big safety feature for the patient, and so as the nurse you will advocate for this patient and make sure that the timeout is done properly. So as far as collaborative care goes, what we can do as nurses in the OR, the operating room, we may be a holding nurse, a circulating nurse, a scrub nurse, or a specialty nurse. And so other nursing interventions that we must think about in the intraoperative phase is implementing your role regarding or according to established standards, always operating within the scope of your practice and the scope of your training. You want to, as a nurse, maintain a safe environment, ensure strict asepsis, so maintaining those sterile fields, applying grounding devices, ensuring correct sponge, needle, and instrument count, position the client in the appropriate fashion based on the procedure, remain alert to complication. So this is not a time to daydream and think about your grocery list. Okay, so stay focused. We also want to communicate with the surgical team. So there may be therapeutic measures that may have to be or may be implemented during the intraoperative phase, and those therapeutic measures may be blood transfusion, radiology, biopsy, or laboratory profiles. Now that we've completed the intraoperative phase, let's talk about the postoperative phase. And that begins when the client enters the post-anesthesia recovery area and continues until discharge from the healthcare facility. So for collaborative care, let's think about the nursing interventions. So this is during the immediate recovery period. So this is as the patient first comes out of the operating room. We have to perform ongoing assessments on this patient. A pulmonary assessment, we're verifying the airway and checking for a gag reflex. We're assessing for bilateral breath sounds, and we're also encouraging the patient to cough and deep breathe. Our ongoing circulatory assessment consists of comparing vital signs to the baseline vital signs, and we're also assessing tissue perfusion by checking cap refill or capillary refill. Our neurological assessment consists of evaluating the level of consciousness of our patient and assessing the reflexes and movement. Our ongoing genitourinary assessment will consist of monitoring the I's and O's. We will assess urinary output, and we'll always look at the color, the clarity, the consistency, and the amount of urine for this particular patient. Our ongoing gastrointestinal assessment consists of listening or auscultating for bowel sounds and assessing for abdominal distension. Our ongoing integumentary assessment is looking for the color, looking at the wound, and looking at the drainage of the insertion sites. That is something that we have to carefully monitor. We have to monitor that skin integrity. So other nursing interventions that take place in the postoperative phase is verifying the IV fluid to make sure that it's the correct fluid and it is flowing at the correct rate. And you also want to make sure you perform an assessment of the IV site. You want to always check for dressings, the type of dressing, and you also want to check if there's any drainage that is visible on those dressings. If there is drainage, we must identify it, including the amount and the color. Is this drainage, is it sanguineous, is it serosanguineous, or is it serous? Those are things that we have to really understand about the drainage. And so when I say that there's serous, that means it's clear. But if it's sanguineous, then that is indicating that there's blood. But if it's serosanguineous, that means it has blood and clear fluid as well, plasma. Okay. If the patient has an NG tube, we'll determine the type and the amount of suction that is ordered. And we want to make sure that we position the patient in the semi-Fowler's position to facilitate maximum oxygenation. So we also want to carefully monitor the patient's temperature to make sure that they are thermoregulating. As you may or may not know, it is absolutely freezing in the operating room, so we want to make sure that the temperature, the patient's temperature comes back to a normal temperature. Okay, the other thing that we have to look at is making sure that the patient is NPO until they are alert and they have a gag reflex. We also want to prevent complications. So our follow-on slides will talk to any complications, and these are common postoperative complications. So the first one is atelectasis. So atelectasis is a condition where the lungs collapse partially or completely. So the occurrence of atelectasis is within the first 48 hours. And so how it manifests itself in the patient is tachycardia, tachypnea, and shallow respirations. Your nursing interventions in order to prevent this complication will be using the incentive spirometer or having the patient use the incentive spirometer. We will turn the patient, have them cough and deep breathe every 2 hours. We will encourage early ambulation and hydration, and we will monitor the respiratory rate and rhythm. So that's how you can prevent atelectasis in your postoperative patient. The next potential complication is hypostatic pneumonia. Hypostatic pneumonia is a type of pneumonia associated with elderly or debilitated people who remain in the same position for long periods. So automatically your nursing mind should say, I'm going to turn and reposition this patient every 2 hours. And I will tell you that your nursing mind is right. Fluids tend to settle in one area of the lungs, increasing susceptibility to infection. So the occurrence for this potential complication is after 48 hours. The manifestations of hypostatic pneumonia are the patient has a fever or they're febrile, tachycardia, tachypnea, crackles, and bronchi. Okay, so the interventions that we would implement would be use of the incentive spirometer, turning, coughing, and deep breathing every 2 hours, early ambulation, hydration, and mucolytics. And mucolytics are designed to decrease the amount of secretions. Now let's look at respiratory depression. And so this is also known as hypoventilation, and it's a breathing disorder characterized by slow and ineffective breathing. So the occurrence can be immediately after the procedure, up to 48 hours. So the manifestations of this in your patient will be bradyapnea, shallow respirations, decreased level of consciousness. So the interventions you should implement for this patient to prevent respiratory depression is monitor the respiratory rate and rhythm, monitor their level of consciousness, regulate narcotics, oxygen therapy, and then always have that narcotic antagonist handy, naloxone. Okay. The next potential complication for a patient that is post-operation is going to be hypoxia. Hypoxia is a below normal level of oxygen in your blood, especially in the arteries. So hypoxemia is a sign of a problem related to breathing or circulation and may result in various symptoms such as shortness of breath. And hypoxemia is determined by measuring the oxygen level in a blood sample taken from an artery via the arterial blood gases. So the occurrence of hypoxia or hypoxemia can occur immediately up to 48 hours post-procedure. How it manifests itself in the patient: by confusion, they may have increased blood pressure and increased pulse, as well as tachypnea. So what will we do? How will we intervene to prevent this from happening to our patients? We will monitor their vital signs, administer oxygen therapy as ordered by the physician, and we will resolve the underlying problem, whatever it may be. The next potential complication of surgery is nausea, and it could occur, nausea is a general term describing queasy stomach, and so the patient may feel that they have to vomit or they may actually vomit. So this may occur immediately up to 48 hours, and so the manifestation is the patient will tell you, I feel nauseous or I feel sick to my stomach. So your nursing intervention will be to provide comfort measures, relaxation, really good mouth care, maybe administer an antiemetic. And so I would submit to you, if the patient has been actively vomiting, I would probably try to get an order for an IV antiemetic. That's going to be the best bet, because if you give an oral antiemetic, they probably will not be able to keep it down and it will not be effective. Another intervention may be an NG tube to the stomach to decompress the stomach. Okay, so that is nausea. So another potential complication is shock. And so shock is an acute medical condition associated with a fall in blood pressure. And so it could be due to a lot of different reasons, but more than likely in your post-operative patient, it's due to hemorrhage. They are bleeding internally somewhere. And so this patient may present with cold, pallid skin, irregular breathing, a rapid pulse, and dilated pupils. So the occurrence for this is immediate to 48 hours. And the manifestations of this patient that is in shock is a decreased blood pressure and pulse and decrease in urinary output. The skin is cold and clammy and pale. The patient may also present with lethargy and they may be in a stupor. So how do you prevent your patient from going into shock? You monitor the vital signs very carefully. You also want to replace any fluids lost, position the patient in a modified Trendelenburg position, monitor the I's and O's, the level of consciousness, and also administer vasopressors as prescribed. Next, we'll talk about urinary retention and hesitancy. And so this is the inability of the patient to voluntarily void urine. So this condition can be acute or chronic, and the causes of urinary retention are numerous and can be classified as obstructive, infection, inflammatory, pharmacologic, neurologic, or maybe other. So in your post-operative patient, a lot of times it could be maybe due to obstruction, or it could be chemical or pharmacologic due to a response from the anesthesia. So this occurrence can be immediate up to 3 days because the effects of the anesthesia can last in your patient that long. So the manifestations of this will be the patient's inability to void. They may have bladder distension, restlessness, and increased blood pressure. So how do you prevent your patient from having urinary retention or hesitancy? Well, you will provide them privacy. We may have to do a periodic bladder scan, offer the bedpan, and you want to carefully monitor their I's and O's. So another potential complication of your patient that is post-operative is decreased peristalsis or a paralytic ileus. So a paralytic ileus is a paralysis of the intestine. It is a complicated medical condition that is characterized by partial or total non-mechanical obstruction of the large or small intestine. This blockage occurs when the intestinal muscles suffers a paralysis. And so this could be due to a side effect of the medication or of the anesthesia. So the occurrence happens 2 to 4 days post-operative. The manifestations is the patient has hypoactive or absent bowel sounds, and there is no flatus, so the patient does not have any gas. The interventions, well, expect that this patient may have a nasogastric tube inserted to decompress the stomach. We want to limit narcotics because we know that narcotics actually slows down the peristalsis in our intestines. We also want to encourage ambulation if it's possible, because ambulation will actually promote the peristalsis. We may have to administer prokinetic agents and any medications as prescribed. The next potential complication is a wound hemorrhage. So a post-operative hemorrhage is bleeding after a surgical procedure. The hemorrhage may occur immediately after the surgery, or it may be delayed. So we also need to understand that it may not be just by the surgical wound. It could be around the area of the surgical wound. Okay, so for the wound hemorrhage, what's going to happen is tissues cannot be prevented from bleeding, and so we depend on the blood clotting to stop the hemorrhage. And so problems in normal clotting, the normal clotting mechanism of blood, and clips or ties around the blood vessels become loose. So that's why it's very important as nurses that we monitor that wound. And the nurses will not be the one to remove the first dressing. That first dressing will stay in place for the first 24 hours, and then the surgeon will be the one to come and actually remove that first dressing. Okay. Now, if you notice that there's a lot of blood or there's a lot of discharge on the dressing, you want to carefully monitor that, and you want to possibly notify the physician. Okay, if it does continue to spread, the discharge does continue to spread. So the occurrence for wound hemorrhage may be immediately up to discharge of the patient from your facility. The manifestations are bleeding from drainage tubes or surgical sites and signs of shock. And signs of shock we discussed earlier, and one of the biggest telltale signs is a drop in your blood pressure. So interventions. So as a nurse, you will always assess the site, identify the early signs of hemorrhage, monitor the drainage device, keep the patient monitor the drainage device, and then avoid tension at the surgical site. All right, the next potential complication is thrombophlebitis. So thrombophlebitis is an inflammation of the vein with the formation of a thrombus. So the occurrence is 7 to 14 days post-operative, and the manifestations are redness, warmth, calf tenderness, pain, edema at the site. So your nursing interventions consist of encouraging the patient to ambulate early and often, apply anti-embolic stockings or sequential compression devices as prescribed, avoid actions that decrease venous flow, and anticoagulant prophylaxis. The next potential complication for your post-op patient is delayed wound healing. So this occurrence may take place 5 to 6 days post-operatively. The manifestations consist of edema, redness, pallor, separation at the edges, absence of granulation tissue. And we want the wound to have granulation tissue because that shows that the wound is healing. So interventions for this is teaching the patient how to splint the incision, so using a pillow to apply pressure if the patient has to cough, laugh, or sneeze. Using an abdominal binder, that might be something that may be helpful to the patient. And you also want to promote a high protein diet because we know that protein helps wound healing. Okay, another potential complication for your postoperative patient is wound infection. So sometimes the patient may get their wound infected by Staphylococcus aureus. And so contamination from other parts of the body, because we have bacteria on our skin, can actually potentially infect the wound. So the occurrence of wound infection is 3 to 5 days, keeping in mind it takes about maybe 48 hours to 72 hours for the bacteria to actually start growing and reproducing if they're in an environment where they can grow and reproduce. So the manifestations of a wound infection are signs of delayed healing with purulent discolored drainage, pain in the incisional area. So purulent drainage means that it's malodoriferous, and you will definitely remember that smell. So your nursing interventions consist of promoting healthy diet, adequate fluid intake, adequate rest, and exercise. You also will perform wound care as prescribed by the doctor. So sometimes you have a doctor's order to irrigate the wound or use specific cleansing products, but you will always care for that wound in accordance with the doctor's orders. For a wound infection, you may also expect that antibiotics may be prescribed. The next potential complication is wound dehiscence or evisceration. And so wound dehiscence occurs when a surgical incision reopens either internally or externally. In addition, an opening could lead to evisceration. And so this evisceration is much more severe. And so when the wound edges are no longer approximated, they're no longer touching, the internal organs may actually protrude out of the incision. So this occurrence can happen 14 to 15 days postoperatively, and so the manifestation is an open wound revealing underlying tissue, that is dehiscence, and if you see organs, that is evisceration. So how can we as a nurse prevent our patient from having wound dehiscence or evisceration? Position the client to decrease tension at the suture line, apply sterile saline soap gauze, notify the surgeon, instruct the client not to cough or strain, and also provide emotional support. Many times the doctors or the surgeons will tell the patient do not lift anything heavy, and so as a baseline they say anything heavier than a gallon of milk, because everyone kind of knows how heavy a gallon of milk is. So that's a good key. And it may be maybe not lifting anything at all, depending on the procedure and depending on the patient's situation. Okay, but you definitely want to avoid wound dehiscence and wound evisceration. Wound evisceration is a medical emergency, and they will probably have to go back into surgery to make those repairs. So our last complication, potential complication, is urinary tract infection. And so this is an infection that involves possibly the kidneys, the ureters, the bladder, or the urethra. So the occurrence is 5 to 8 days. And so the manifestations of a urinary tract infection, or a UTI, will be frequency, urgency, dysuria, malodorous, or cloudy urine. Okay, so the patient will have difficulties emptying their bladder, or when they're actually emptying their bladder, it may be painful, and their urine will have a foul smell, and it will be cloudy. You may see sediment in their urine. So your nursing intervention to prevent this from happening is to instruct the patient to wipe from front to back after urination, limit the use of indwelling catheters, encourage voiding, increase fluids to 3 liters a day, have the patient take a cranberry juice, antibiotics as they are prescribed, and uroanalgesics as prescribed. All right, so now that we have talked about your perioperative care, so that includes your preoperative, your intraoperative, and your postoperative, I have some NCLEX style questions for you. So here's the first one. The nurse is caring for a client postoperatively who develops sinus tachycardia. Which of the following interventions should the nurse perform? 1. Should the nurse apply warm blankets, manage the client's anxiety, position the client in the left lateral position, or administer atropine sulfate? Take a minute to think about it. And here's a test-taking strategy. Always read the full question and read all the choices before you determine what the answer is. So read the full question, think about what the question is asking you, and then read all the choices. So hopefully you selected choice number 2, managing the client's anxiety. Okay, managing the client's anxiety. And it's important to do that because we know that sinus tachycardia means that their heartbeat is outside the normal range. The normal heartbeat for an adult is 60 to 100 beats per minute. And so we do know that anxiety can create a situation where the patient's heart rate will race. Okay, so once we manage their anxiety, maybe get them to calm down a little bit, that might decrease their heart rate. So that will be the first thing that you would do. The other options are not appropriate. The next question is, the circulating nurse and the scrub technician find a discrepancy in a sponge count. And so this is actually during the surgery. This is in the intraoperative phase. Which action should the circulating nurse take first? Should the circulating nurse complete an occurrence report? Should the circulating nurse contact the surgical manager? Should the circulating nurse recount all sponges or notify the client's surgeon? Take a minute to think about it. And the correct answer is the first thing, and this is a priority question. What would the nurse do first? And recount all the sponges. So all of the other things are things that the circulating nurse might do, but what will this nurse do first? So this concludes our NCLEX huddle on perioperative care. I want you to, if you need to, review this video again. If you have any questions, feel free to contact me. And I want you to remember, always think like a nurse. See you next time.